1, 2, 3, 4, 5. Yep. The committee will come to order. A quorum is present. Without objection, the chair is authorized to declare a recess at any time. Since we're working in a virtual format today, I'd like to go over a few housekeeping items before I proceed. First, if you're experiencing connectivity issues, please make sure you or your staff contact our designated technical support so it can be resolved immediately. Members participating remotely must continue to use the video function for the duration of their participation in the hearing unless they experience connectivity issues or other technical problems that render the member unable to fully participate on camera. It is committee policy that members will remain muted when not recognized, just like turning your microphone on and off during a hearing in person. This is out of courtesy to all members on the committee so that background noise does not interfere with another member who is recognized to speak. When you are recognized, you will need to unmute your microphone and pause for a couple of seconds before speaking so we will be able to hear everything that you say. If you wish to be recognized, please raise your hand using the Zoom raise hand function, unmute your microphone, and ask to be recognized. In order to ensure everything members say is captured on the live stream of this hearing, I ask that members pause for 2 to 3 seconds before beginning to speak. If you wish to have a document inserted into the record, please ask for unanimous consent and have your staff email the document to veteransaffairs.hearings@mail.house.gov. It will be uploaded to the committee document repository. Please keep in mind that you will need to refresh the repository page as it does not automatically update. Without objection, members will be recognized in order of seniority for questioning witnesses. This makes it easier for me to make sure all members participating have an opportunity to be recognized. Does any member have a question about the conduct of this hearing with members participating remotely? Seeing none, I now recognize myself for an opening statement. Good morning. Thank you all for joining us today for the Health Subcommittee's legislative hearing. Today's agenda includes 13 bills that would address some of the most important health challenges our veterans face, including the need for COVID-19 and seasonal flu vaccines, speedier access to higher quality mental health care in VA facilities and vet centers, culturally appropriate suicide prevention outreach for our Native veterans, challenges recruiting and retaining VA nurses and physician assistants, and access to VA healthcare services for our World War II veterans. We also will consider a bill directing VA at long last to conduct a rigorous clinical trial investigating the effectiveness of various forms of cannabis for easing veterans' suffering. Importantly, we also will discuss my bill to expand VA access to mammography and other medical options for veterans at risk for breast cancer. Women who have served in the military are 20 to 40% more likely to develop breast cancer than women who have never served. It is believed this is because of exposure to radiation and other carcinogens while serving. Across the veteran and non-veteran population, men with breast cancer have higher mortality rates than women, most likely because their cancer is diagnosed at an older age and is at a more advanced stage by the time it is diagnosed. It is therefore critical that VA ensure all veterans have access to prompt, high-quality breast imaging services to detect breast cancer early and access to genetic testing to identify individual breast cancer risk. My bill requires VA to establish a strategic plan for breast imaging services and creates a telemammography pilot program to better serve veterans in rural areas. Within 2 years of enactment, VA will be required to provide a 3D breast imaging at facilities where it offers mammography services and report to Congress on which VA facilities offer these services. In addition, my bill mandates a VA study on veterans' current access to testing for breast cancer genes and the feasibility and advisability of expanding veterans' access to the service. VA is also directed to study the physical accessibilities of mammography services for paralyzed and disabled veterans and the rate at which these veterans are accessing such services. Finally, it would increase VA's partnership and collaboration with breast cancer research programs at the National Institutes of Health and the Department of Defense. In closing, I look forward to today's conversation. Your expertise and input are valuable to us as we craft legislation. Before I recognize General Bergman for his opening statement, I'd like to acknowledge that Chairman Decano is joining us today. He will forgo an opening statement and save his comments for his 2 bills on the agenda today. With that, I would like to recognize Ranking Member Bergman for 5 minutes for any opening remarks he may wish to make. General Bergman?
Thank you, Chairwoman Brownlee. I appreciate the opportunity to gather virtually to consider 13 bipartisan bills to better support service members, veterans, and their families. But before I turn to the bills under consideration today, I must mention 3 bills that are regretfully not on the agenda this afternoon. The first of those is my bill, H.R. 4624, the Guaranteeing Healthcare Access to Personnel Who Served, or GAPS Act. The GAPS Act would make a number of improvements to the VA healthcare system, making it more accessible to American veterans and accountable to American taxpayers. The GAPS Act is bipartisan, and it is a companion to a bill introduced in the Senate by Senate Committee on Veterans Affairs Ranking Member Moran and reported out of Senate Committee on Veterans Affairs with bipartisan support this summer. The second one of those bills is Ranking Member Bost's bill, H.R. 291, the VA Cost Savings Enhancement Act. The VA Cost Savings Enhancement Act would require VA to consider expanding the use of on-site medical waste management systems in VA medical facilities. On-site medical waste management systems are a best practice for infection control and emergency preparedness throughout the healthcare industry. The Cost Savings Enhancement Act was considered favorably by this subcommittee in prior Congresses and could play a critical role in our ongoing efforts to make VA a more environmentally friendly and responsible steward of taxpayers' dollars. The last of those bills is Dr. Biller Meek's bill, H.R. 2932, the Veterans Cannabis Analysis, Research, and Effectiveness, or CARE Act. The Veterans CARE Act is based on legislation that passed the committee with bipartisan support the last 2 Congresses. It is similar to legislation that is on our agenda today, H.R. 2916, the VA Medicinal Cannabis Research Act of 2021, sponsored by Congressman Correa. However, Dr. Miller-Meek's bill is much less prescriptive than Congressman Correa's bill and much more likely to produce actionable results about the effects of medicinal marijuana on veterans with PTSD, chronic pain, and more. Republicans have been advocating for the Veterans Cares Act to be considered by this subcommittee all Congress. We have also been advocating for the GAPS Act and the VA Cost Savings Enhancement Act. It is disappointing that they are not on this legislative agenda. I sincerely hope that they will be on the next legislative hearing agenda. That said, there are many bills under consideration today that I look forward to discussing. I am particularly eager to discuss Dr. Miller-Meek's bill to improve support for veterans involved with the criminal justice system, Congressman Elsey's bill to improve support for student veterans, and Congressman Rouser's bill to improve support for the families of veterans who die by suicide. Each one of those proposals would deliver much needed care to vulnerable at-risk groups that really deserve and need a helping hand. In doing so, that would bring us one step closer to ensuring timely access to high quality care and services and eradicating veteran suicide once and for all. Many of the other bills before us today share similar goals. I'm grateful to the sponsors of each of those bills and to our witnesses for being here to offer their views and perspective. And with that, Madam Chairman, I yield back.
Thank you, General Bergman. We will now welcome our first panel, where we will hear from colleagues who have sponsored legislation on today's agenda. I will begin by recognizing Chairman Takano for 5 minutes for any remarks he may wish to make in support of his two bills, the VA Governor's Challenge Expansion Act and a draft bill that would allow VA to furnish flu shots to individuals eligible for COVID-19 vaccines under the Saves Lives Act. Chairman Takano, the floor is yours.
Thank you, Chairwoman Brownlee, and I'm certainly impressed by the ambitious agenda you have today at this legislative markup or legislative hearing. Thank you. I'm pleased to speak on my two bills, the VA Governor's Challenge Expansion Act and a discussion draft of legislation giving VA authority to provide seasonal influenza vaccines to individuals who are eligible for COVID-19 vaccines under the Save Lives Act. I was pleased to introduce H.R. 5317, the VA Governor's Challenge Expansion Act, along with Congresswomen Porter and Slotkin. This bill gives VA two important new authorities within its very successful Governor's Challenge Veteran Suicide Prevention Program. First, it directs VA to treat tribes equal to states for the purpose of inclusion in the program. Native American veterans serve at disproportionately high rates and are at increased risk of suicide, and tribes are sovereign nations that cross state boundaries. That's why our bill ensures tribes are recognized by the Governor's Challenge Program as having their own unique strengths and needs when it comes to their veterans. Second, the bill allows VA to provide not only technical assistance to states and tribes, but also provide funding for the actual implementation of tailored state and tribal veteran suicide prevention proposals. This is vital to move quickly from developing local suicide prevention proposals into action. And right now, states have to seek external funding to implement prevention programs. And we know that external funding is difficult to come by and often unsustainable in the long run. So I see in today's testimony that VA supports the Governor's Challenge Expansion Act, but would like to work with the committee to ensure that the bill language does not require a long rulemaking process on VA's end. We agree that a delay would be problematic and are happy to work with the VA to edit the text to avoid that. My second bill relates to seasonal influenza vaccines. Public health experts have determined that administering COVID-19 vaccines and influenza vaccines at the same time is not only safe, but recommended. And that is why I've drafted language that would modify VA's authority under Save Lives Act to also provide flu vaccines to the very same population. This bill was passed unanimously in both the House and the Senate earlier this year. By providing easy access to both vaccines at the same time, I hope we can begin to reduce the burden on the broader healthcare system this winter. Earlier this year, as the Delta variant surged, hospitals across the country reached breaking points. Healthcare workers had to turn patients away, some of whom died because emergency departments were overrun with COVID cases. CDC estimated that during the 2019-2020 influenza season, there were 18 million medical visits, 405,000 hospitalizations, and 22,000 deaths. I'm sure healthcare workers would appreciate avoiding these 405,000 hospitalizations for flu this year. I noted DAV raised concerns in their testimony that about this change, setting a precedent moving forward for VA to provide other preventative care for veterans' families, family members, and caregivers. I appreciate DAV's concern, but I would also note that the underlying Save Lives Act is specifically tied to this public health emergency. These are unprecedented times, and as a result, we should be open to thinking outside the box to better public health. Thank you again, Chairwoman Brownlee, for holding today's hearing and for the subcommittee's consideration of all the bills on today's agenda, and I yield back.
Thank you, Mr. Chairman, and I certainly would be remiss if I didn't compliment you on your two bills as the chairman of the committee. So congratulations on that. And now I recognize Representative Peters. Welcome back to the committee. You're now recognized for 3 minutes to deliver remarks in support of your legislation, HR 4575, Veteran Peer Specialist Act of 2021. Welcome.
Thank you, Madam Chair and Ranking Member Bergman. It is a pleasure to join the committee again. Thanks for hosting the legislative hearing, considering a variety of really important bills that address veteran mental health issues and support healthcare that serve our veterans. I'm very grateful and thankful that my bill, the Veteran Peer Specialist Act of 2021, is included in today's hearing. It's a continuation of another bill I introduced in 2018, the Veteran Partners' Efforts to Enhance Reintegration, or PEER Act. At the time, VA peer specialists primarily worked in behavioral health settings where many vets did not seek the help they needed because of the stigma associated with mental health care. This bill addressed this issue, the PEER Act, by embedding peer specialists in primary care settings, and that became law as part of the VA Mission Act. The legislation before us today the PEER Act expanded VA's peer counselor program by embedding peer counselors on patient-aligned care teams at 25 VA healthcare sites. This expansion integrated services for mental health, substance use disorder, and behavioral health in primary care settings, which exposed more vets to mental health care. Furthermore, Congress required VA to report back on the program's effectiveness to ensure that the program worked as intended and encouraged VA to engage with local community care providers. Today's bill, the Veteran Peer Specialist Act of 2021, is step 2 in our effort to expand veteran peer counseling. The bill you're considering today would make permanent the peer specialist program in all VA medical centers over a 5-year period by growing the program at 25 VA medical centers per year, hiring 2 peer specialists at each facility, and ensuring racial and geographic diversity in the hiring of peer specialists. If passed, this bill would authorize $5 million annually for the next 5 years to support the program. Senators Blumenthal and Blunt have introduced companion legislation in the Senate. I hope hopefully you will all favorably report out the bill out of the committee this year, and I encourage all of my colleagues to support this bill. In particular, I want to thank Representatives Allred and Mann for co-leading this bill with me and the over 20 veteran and mental health advocacy groups that have championed this important legislation. I want to specifically include 2 of my constituents, Howard and Jean Somers, who tragically lost their son to suicide in 2013. Thanks very much for allowing me to join you at the committee today, and I yield back.
Thank you, Mr. Peters, and really good bill. I don't want to stand in the way of your bill if you have companion bills over in the Senate, but I would like to talk to you about potentially carving out something for women in your bill, because what we have discovered is that when it comes to peer support, peer specialists, there are not enough for women, and many women prefer women in that regard. So I'd like to talk to you about it at some other point in time. So
great. That's certainly consistent with the concept of peers.
Yeah.
Who have had the same experience. So we'd love to chat with you, Madam Chair, and thanks again for having me.
Thank you, Mr. Peters. I now recognize Representative Rouser for 3 minutes to discuss HR 5029, expanding the Families of Veterans Access to Mental Health Services Act. Mr. Rouser.
Thank you, Madam Chair, and Ranking Member Berger for the opportunity to testify regarding HR 5029, expanding the Families of Veterans Access to Mental Health Services Act. Over the past year and a half, many families have struggled with the emotional effects of changes made to mitigate the spread of COVID-19, as well as fighting the virus itself. But few individuals have been more impacted by the virus, the emotional duress, and the financial stress it has caused in so many cases than veterans and their families. In the worst and most lamentable cases, veterans have taken their own lives, leaving their family looking for a guiding hand and counseling to help them cope. This is precisely why I introduced legislation spurred by the experience of a constituent who has dealt with just such a tragedy. In this particular case, she faced complications when trying to receive critical mental health support for herself while remaining the sole caregiver for their children. Grief can be extremely isolating, and the families of service members and veterans who have died by suicide should not have to endure the difficult journey alone. Passage of this legislation into law would mean that these families can receive the critical mental health services they need to help guide them through that recovery. The bill would expand services already offered by veteran centers to family members of those veterans and servicemen and women who have died by suicide. The healing process is very much and often long-term. So this legislation would retroactively cover families of veterans and service members who have died by suicide prior to enactment of this legislation as well, so that no family in this particular category is left to bear their burdens alone. Again, I want to thank the chair and ranking member for the opportunity to testify on this important legislation. I appreciate the committee's interest and support of this bill, and I look forward to working with you to help ensure its passage. With that, I yield back.
Thank you, Mr. Rouser. Great bill. I think the whole committee, we love our vet centers, and they do such a great job. And one of the big benefits of vet centers, in my opinion, is that it stands outside of the bureaucracy of the VA, and it's local and it's community. And so thank you for a good bill.
Thank you.
I now recognize Representative Delgado. You're recognized for 3 minutes to deliver a statement in support of your bill, HR 5073, the revising and expediting actions for the Crisis Hotline for Veterans Act, or the REACH Act. Welcome.
Thank you. Thank you, Chairwoman Brownlee, Ranking Member Bergman, for the opportunity to speak in support of my bipartisan bill, the REACH for Veterans Act. In August, I had a powerful veterans forum in my district, the New York's 19th Congressional District. We heard from veterans, local leaders, advocates, all of whom stressed the same point. Veterans, especially those who have served post 9/11, are really struggling. Studies estimate that over 30,000 post 9/11 veterans have died by suicide, more than 4 times the number of service members who gave their lives during post 9/11 military operations. We must do everything in our power to be there for the brave men and women who served in uniform and protected our freedom. My bill, the Bipartisan REACH for Veterans Act, would institute several critically important improvements to the Veterans Crisis Line, or VCL. The VCL has answered more than 5.6 million calls since it was established in 2007 and dispatched emergency services to more than 204,000 callers in crisis. It is essential and it has saved lives. However, a series of reports recently published by the VA's Inspector General highlighted serious shortcomings in the VCL's training for call responders and in the VA's management of the hotline. Our legislation implements the suggested reforms outlined in those reports, and the bill would specifically require an outside evaluation of VCL's current training curriculum, direct the VA to issue retraining guidance for call responders, increase the quality review and management other VCL calls and processes, improve responder guidance for high-risk callers, and establish pilot programs to improve VCL services. The bill would also facilitate the VCL's transition to 988 as part of the National Suicide Prevention Hotline, making it easier for veterans to find help when they need it most. I'm honored to say that my bill is endorsed by many of our nation's most prominent VSOs, including the American Legion, Disabled American Veterans, Iraq and Afghanistan Veterans of America, Paralyzed Veterans of America, Veterans of Foreign Wars, and the Wounded Warrior Project. These VSOs who do the work on the ground day in and day out to support American veterans of all eras know what an important role the VCL plays. As a nation, we are forever indebted to the brave men and women who serve our nation in uniform. It is our solemn obligation as elected officials and as Americans to care for our veterans when they return home, whether their wounds are visible or not. When our nation's veterans find themselves in a moment of crisis, it is essential they have the resources that they need. I urge the committee to join me in supporting this critical legislation. Thank you to Representatives Mann, Cheryl, Miller Meeks for leading this bill with me in the House, and Chairman Tester and Ranking Member Moran for their work on this bill in the Senate. I yield back. Thank you for your time.
Thank you, Mr. Delgado. Again, great bill. When it comes to our crisis hotline, the VA needs to be always in a continuous improvement cycle. We've got to make it better and better all the time, so it's foolproof. So thank you for bringing an important bill forward. I now recognize our subcommittee's newest member, Mr. Elsie, for any comments you wish to make about your bill, HR 5516, the Vital Assessment Act.
Thank you, Chair Brownlee, Ranking Member General Bergman, and members. I'm honored to present this bill for the subcommittee's consideration. Veterans are a top priority of my legislative agenda, and it's only fitting that we as Americans take care of those who have taken care of us on the front lines. 22 veterans die from suicide every day, and of course, we all know that number, and it is unacceptable. I think we should do all we can to help our veterans by looking at the veterans as a whole person, help them acclimate to their new lives as civilians, and prevent these deaths. The VITAL program is an essential program that has proven to save the lives of our veterans, and the Vital Assessment Act will give us the additional tools and resources needed to improve the program. As a veteran and having served on the Texas Veterans Commission for 6 years, I know the transition from military to civilian life usually isn't smooth, and support can be important in dealing with the stress in a productive and healthy way. In fact, admittedly, after 20 years in the military, that was an interesting process for me as well. Hundreds of thousands of veterans attend school every year using the GI Bill. I was one of them, and other earned educational benefits from the Department of Veterans Affairs. Student veterans that earn their education benefits in service to our country. And according to VA, student veterans often have difficulty adjusting from military culture to campus culture. Student veterans have unique needs and experiences that can make college particularly stressful. Veteran students might struggle to relate to their non-veteran peers at school due to differences in age, experiences, and expectations. Indeed, 62% of student veterans are first-generation college students. In 2011, VA launched the Veterans Integration to Academic Leadership Program, long way to get to the VITAL program, to provide mental health services to student veterans on college campuses. Since then, it's grown to support student veterans at 183 locations. VITAL is locally managed, staffed, and evaluated by VA medical centers working with area schools. And while that allows for independence and flexibility, it does not allow for critical information about VITAL to be tracked by VA central office so that best practices can be identified and the mental health needs of student veterans can be prioritized. So this legislation, the Vital Assessment Act, is aimed at ensuring information about VITAL program is collected and analyzed as a means of improving the program. It requires the VA to report to Congress about VITAL's management, operations, and effectiveness in supporting student veterans' mental health and educational goals, connecting student veterans with needed care and services, and preventing student veteran suicide. It requires the VA to consider including student veteran suicide statistics in VA's annual suicide data reports. In summation, the Vital Assessment Act will support student veterans' mental health and help them achieve their goals and dreams. So I'd like to thank the Student Veterans of America for their advocacy for this legislation. And I'd like also to thank Ranking Member Boss for being an original co-sponsor of this bill. His support is greatly appreciated. I look forward to working further with him and with all members of the committee to help advance this legislation. Thank you for allowing me to testify on this bill. At the appropriate time, your favorable consideration to pass would be greatly appreciated, and I yield back.
Thank you, Mr. Elsie. Another good bill. We need all of our mental health services to touch on every veteran who needs it. So reaching out specifically to student veterans is extraordinarily important. So thank you for that. I now recognize Mr. Harder for 3 minutes to speak on his draft bill to expand eligibility for hospital care, medical services, and nursing home care from VA to veterans of World War II.
Well, fantastic. Thank you so much, Chair Brownlee, for having me today. Today, I want to highlight an issue that, regardless of the amount of lip service folks in Washington sometimes give it, is still way too big a challenge. And that's healthcare for our veterans, especially our aging World War II vets. Right now, despite their heroic service to our nation, more than 1 in 4 veterans of the Second World War aren't using the healthcare benefits that they've earned. That means more than a quarter of the men and women who defeated fascism, kept our nation free, aren't receiving the medical services, the in-home care, the nursing home care, and the hospital care that our nation promised them when they put on the uniform so many decades ago. And we know exactly why this is happening. It's happening because means testing restrictions are excluding those veterans from getting services at the VA. So I'm here today with as simple a fix as there is. I'm proposing the World War II Veterans Hospital and Medical Eligibility Act. This whole bill is less than 1 page. It says that every World War II veteran, no matter who they are or where they're from, is eligible for full health care benefits from the VA by exempting them from this means test. With the passage of this bill, any World War II veteran who was not previously enrolled in healthcare, VA healthcare, would have access to this expanded automatic eligibility. We did exactly the same thing for veterans of the First World War. Now it's time we do it for the greatest generation as well. Today, I'm asking that we stop tripping over red tape and needless rules and start delivering healthcare for the World War II veterans we're lucky enough to call our parents, our neighbors, and our friends. We can never repay the men and women who kept us free all those years ago. We can provide them with the health care that they deserve as they live out their golden years, surrounded by their kids, their grandkids, and even their great-grandkids. Thank you. I look forward to working with my colleague, Representative Vella, the American Legion, who've been a big help in putting this bill together, and Republicans and Democrats alike to get this bill signed into law so every World War II veteran can age with dignity and respect. Thank you, and I yield back.
Thank you, Mr. Harder. Another really great bill. And as you said, the greatest generation in their golden years only deserve our respect for their service, our gratitude for their service, and they should be dignified in any kind of health care that they need from the VA. So, and we lose so many every single day. It's the least we can do is to reach out to these veterans and provide them with the very best of VA services. So thank you for putting this forward. Up next, we'll hear from Congresswoman Underwood, you now recognize for 3 minutes to highlight your draft bill, the VA Nurse and Physician Assistant RAISE Act.
Yes, ma'am. Thank you, Madam Chair. And thank you for including my new bipartisan bill, the VA Nurse and Physician Assistant RAISE Act, in today's legislative hearing. Over the course of the past year, our subcommittee and the full Veterans Affairs Committee have examined VA's glaring healthcare workforce shortages. According to a September 2020 report from VA's Inspector General, nursing occupations have been one of the 2 most commonly cited severe staffing shortage jobs within the Veterans Health Administration every year since 2014. These shortages have real consequences. The VA Inspector General has called the department's staffing shortages, quote, a root cause for many of the problems in veterans care. And the problem could be even more severe due to COVID-19, which has intensified demand for healthcare professionals who are simultaneously experiencing high levels of burnout due to the pressures of the past year and a half. We need to take action to ensure that the VA can recruit and retain the clinical workforce that the department needs to provide our veterans with the timely, high-quality care that they've earned no matter where they live. And that's why I am so proud to be introducing the VA Nurse and Physician Assistant RAISE Act with Representative Dave Joyce, who's the co-chair of the Congressional Nursing Caucus. Our bipartisan bill, which is based on proposed legislation from VA in their fiscal year 22 budget submission, would amend the department's pay limitation policy for advanced practice registered nurses, physician assistants, and all other registered nurses. Currently, VA's locality pay system subjects most VA nurses and PAs to an overall pay cap set at level 4 of the federal government's executive schedule. And this limitation means that even as nurses and PAs ascend in their roles, VA's compressed pay scale means it's possible that they won't make any more money, even as they take on greater responsibilities. And this is especially prevalent in high-income areas, including in my state of Illinois, and it impacts everyone from staff nurses all the way up to the chief nursing officers. And the result is that VA cannot attract or retain top talent who could be making more money in non-VA health systems. My VA Nurse and Physician Assistant RAISE Act would address this issue by increasing the pay limitation for VA's advanced practice registered nurses and PAs to level 1 of the executive schedule and to level 2 for all registered nurses. It's the right thing to do for healthcare professionals who make such significant sacrifices to care for those who have served our country. And it's a critical step to ensure that our veterans have access to the high quality care they deserve from the very best clinicians our country has to offer. Now, you know, I'm a nurse, and I'm so proud to be leading this bill on behalf of VA's nurses, physician assistants, and the veterans they care for. I'm so thrilled that VA is supportive of this bill, in addition to the VSOs participating in today's hearing, the Nurses Organization of Veterans Affairs, the Veterans Affairs Physician Assistant Association, and other national organizations. So, colleagues, please support this bill. And I yield back, Madam Chair. Thank you.
Thank you, Ms. Underwood. There's not a better person to carry this bill than you. So thank you for bringing it forward. And it really is so critically important that the VA turn every stone possible to unleash the gateway into the VA for all of these critical positions. And it's, you know, particularly during this last 2 years with COVID, almost 2 years with COVID, we have seen those nurses on the front lines doing their jobs. Anybody that leaves a hospital, the person that they remember is their nurse. They don't really remember anybody else, but they remember their nurse. And and nurses now are, they're in such demand that they are going on registries and getting paid on a daily basis because it's just so competitive out there. So the VA needs to really respond to the market. And so thank you for bringing an important bill forward. So now, Dr. Miller-Meeks, you are now recognized for 3 minutes to tell us about your bill, HR 5529, the Veterans Justice Outreach Improvement Act.
Thank you, Chairwoman Brownlee. I'm proud to have introduced the Veterans Justice Outreach Improvement Act alongside Ranking Member Bost. Veterans that have been incarcerated and are arrested are at a much higher rate for homelessness, substance abuse, mental illness, and suicide. As a 24-year veteran myself, I have a sense of duty to ensure that all veterans have the support that they need. The current VA Veteran Outreach Program, Justice Outreach Program, does not meet the needs of all justice-involved veterans. A 2021 GAO report found that there were deficiencies in regard to the identification of and outreach to justice-involved veterans and the training of VJO specialists. My bill would require that the VA increase the number and improve the training of veterans justice outreach specialists in remote, rural, and underserved areas. Further, I have solicited feedback from the GAO on the bill and intend to review and add their suggestions as it is a top priority of mine to ensure the best care for our veterans. Through VJO, specialists at each VA medical center work with local courts, jails, and law enforcement offices, including those at veteran-specific treatment courts, to identify justice-involved veterans, assess their needs, and connect them with VA benefits and services. In 2020, 36,365 veterans were served through VJO. Ensuring our veterans have access to the benefits and services they have earned is a top priority of mine in Congress, as well as most of us on this panel. The VJO program is incredibly important to supporting our veterans, and there is much work to be done to make sure it reaches every veteran it can help. I am proud to partner with the fellow veteran, Congressman Bost, to help our veterans access available resources and services. I would like to thank Eric Sowers, a VFW Student Veterans of America Fellow, for his contributions to the underlying bill and for his work on VJO. I welcome all members of this committee to support and co-sponsor this legislation. I yield back my time, Madam Chair.
Thank you, Dr. Miller-Meeks. And I have to admit that I didn't know a lot about this particular issue until your bill came forward and I reviewed it. And now I am clear about what the needs really are. And I am a great believer in the veterans courts and hopefully keeping veterans out of incarceration, altogether. But your bill's an important one, and thank you for bringing it forward. So, and last but not least, Congresswoman Carroll, you're recognized for 3 minutes of remarks on your draft bill, the Vet Centers for Mental Health Act of 2021.
Well, thank you so much and good afternoon. I'd like to thank the subcommittee for holding this hearing today and offering this opportunity to advocate for increased vet center access through my bill, the Vet Centers for Mental Health Act. I want to offer my thanks to the subcommittee's chair, Representative Brownlee, and Ranking Member Bergman. I also want to thank one of my partners on this piece of legislation, Representative Sibling, who sits on this subcommittee, as well as give my thanks to Committee Chairman Takano, who has graciously supported this bill. I know that the bipartisan members of this committee are well aware of the mental health challenges our veterans face, particularly our combat veterans and those who have experienced sexual assault. I also know that this committee is well aware of the important work done by the mental health professionals at our nation's vet centers to serve them. Vet centers are routinely identified as the most successful and therefore coveted parts of our VA health system. However, for a host of reasons like shifting populations or accidents of history, some veterans have been locked out of easy access to the benefits of our vet centers. For example, the veteran constituents of our colleague, Representative Sibling, in the Northern Mariana Islands currently have no easy access to VA mental health services whatsoever and are left only with options that require expensive airfare and overnight accommodations, hundreds of dollars from their own pockets to access in-person support. That experience is the extreme, but it's indicative of the challenges that many veterans all across the country must overcome to access the care they need. In my home state of New Jersey, we have the highest population density among all the states, the 11th largest population, despite being the 4th smallest geographically. Our veterans may not need to get on a plane to make it to their appointments, but they do need to fight traffic, inconsistent public transportation access, expensive toll roads, and other obstacles that make it impractical or impossible to consistently make it to badly needed appointments. Even in states like North Carolina, the ratio of veterans to vet centers is nearly double the national average, despite the robust military presence in that state. And in California and Illinois, the combination of sprawling metropolitan areas with rural agricultural areas create challenges for those diverse communities to access services. Unfortunately, because of these obstacles, whether in New Jersey or the Northern Marianas Islands, whether North Carolina or Illinois, many veterans are forced to choose to forego or simply are unable to access vet center services that could save their lives. My bill provides an answer: a modest but strategic increase in the number of vet center locations in states that face challenges like these. Our solution amounts to a less than 4% increase of the total of 300 vet centers nationwide that will make a world of difference to these veterans. All of the states and territories I've mentioned, as well as the underserved states of Minnesota, Ohio, Virginia, Florida, Maryland, and Pennsylvania, states home to 8 million veterans, would see an additional vet center as a result of my bill. Earlier this year, I was honored to be a co-sponsor on Representative Axney's Sergeant Ketchum Rural Veterans Mental Health Act, co-led by Representative Miller Meeks, who sits on this subcommittee. That critically important bill increased much needed mental resources for veterans in rural areas. New Jersey may not have as many rural areas as Iowa, but just like Iowa, just like the Northern Mariana Islands, North Carolina, Illinois, California, Pennsylvania, and Florida, our veterans deserved increased access to potentially life-saving services and unique solutions to combat their current challenges. I humbly ask for your support of my bill. Thank you, and I yield back.
Thank you, Congresswoman. Another great bill. You couldn't have picked a better partner in your bill than Mr. Sibling. So congratulations on making the right choice there. And he's been a huge advocate for veteran services in his district, and particularly for vet centers. And, I am a huge fan of vet centers, and as you described, the need is sorely there. But one of the other important things about the vet center, I said earlier, is that they're outside of the bureaucracy of the VA, but they have the real ability to really reach out to the community and reach out to those veterans who don't know that they exist, reach out to those veterans who are maybe a little leery about utilizing veteran services when it comes to their mental health. So they play such an important role. I know my vet center in my county during COVID, they went out and got these antique cars, and they drove around, called veterans ahead of time, came to their house outside so that they could have contact with a veteran, salute that veteran, thank them for their service. I mean, that's the kind of thing that vet centers will do to come up with kind of creative solutions that the VA would never come up with. Sorry, VA, but it's the truth. So thank you. Thank you so much for putting forward this bill with Mr. Sibling.
Thanks, Chairwoman Brownlee. I appreciate that.
Yeah. So before we move on, would any of the other members on the subcommittee like to make any comments on the bills on the agenda today? If not, we will move on to our second panel. Seeing none, with that, I'd like to now introduce our second panel from the Department of Veteran Affairs. Testifying before us this afternoon is Dr. David Carroll, Executive Director for the Office of Mental Health and Suicide Prevention within the Veterans Health Administration. He is accompanied by Dr. Robert Shearer, Executive Director of the National Teleradiology Program, and Karen Ott, Director of For Policy, Legislation, and Professional Standards for the Office of Nursing Services. And finally, Michael Fisher, Chief Readjustment Counseling Officer. So welcome to you all. I will remind our witnesses to please pause 2 to 3 seconds before speaking so that the recording will capture all of your words. And please remember to do so again when answering members' questions. Your written statement will be included in full in the hearing record without objection. Dr. Carroll, I now recognize you for 5 minutes for VA's remarks on the bills before us. Welcome, Dr. Carroll.
Thank you, Chairwoman Brownlee, Ranking Member Bergman, and other members of the subcommittee. Thank you for inviting us here today to present our views on several bills that would affect VA programs and services. We are most grateful for the committee's support and oversight to ensure that VA has the authorities and resources needed to meet our mission to care for America's veterans. VA's views are provided on all the bills in our written statement, and I will not be able to speak about every bill now. I will highlight a few bills in my remarks, but that is in no way to minimize the importance of any and all bills on the agenda today, and we look forward to your questions. VA supports the draft bill to strengthen and amplify vaccination efforts to locally immunize all veterans and every spouse. That will authorize VA to provide seasonal influenza vaccines in addition to or independent of vaccines for COVID-19. We recommend that if Congress plans to enact this bill, it do so quickly enough to address the peak of the upcoming flu season between December and February. We share the committee's goal, and it is our commitment to ensure that all veterans have access to the highest quality breast imaging services. We are currently finalizing a strategic plan that will address many of the provisions in the Making Advances in Mammography and Medical Options for Veterans Act. And we believe this plan will provide excellent access and quality in mammography for veterans across the nation. On this basis, VA does not support the bill as currently written, and we desire to present to Congress the content of our forthcoming strategic plan for your consideration. VA supports the Expanding the Families of Veterans Access to Mental Health Services Act that would allow vet centers to provide bereavement counseling to family members of veterans and service members who die by suicide. VA also supports the concept of expanding access through vet centers and community-based clinics and reducing barriers to readjustment counseling and healthcare. However, VA has concerns about the methodology for expansion set forth in the Vet Centers for Mental Health Act, which could potentially limit VA's ability to meet the needs of veterans, service members, and families eligible for vet center services. We strongly support the goals of the Veteran Peer Support or Sphere Specialist Act of 2021, but we do not believe it is necessary. VA currently has the authority to hire, and we have nearly 1,200 peer support specialists employed across the system. And we have the experience and technical assistance ready for facilities who want to expand and adapt their current services to a greater extent within primary care clinics. With the committee's support and direction, the Veterans Crisis Line is the world's largest crisis line, providing confidential support to veterans and service members in crisis. The VCL has continually evolving, comprehensive training and quality assurance programs, and it is accredited by several national organizations meeting their standards, including the American Association of Suicidality, the Commission on Accreditation of Rehabilitation Facilities, and the International Customer Management Institute. While VA agrees with the goals for the Reach for Veterans Act, we do not believe it is necessary because we already have sufficient authority in this area, and our current efforts meet or exceed the requirements of the legislation. VA is also grateful for the committee's support of its workforce as seen in the VA Nurse and Physician Assistant RAISE Act. We appreciate the committee's interest in providing VA additional flexibility to compensate nurses and other healthcare professionals. However, we would appreciate the opportunity to work with the committee to develop and propose a few modifications to this bill. Finally, I would like to reiterate that VA is very much in alignment with the goals of all of the bills on the agenda today and appreciates the committee's attention to these important topics. But as detailed in our written statement, there are many instances of duplication with many of VA's current robust ongoing efforts. We want to avoid situations where, despite good intentions, we wind up increasing overhead and burden that complicate or could detract from the delivery of the benefits and services that are so important to veterans. That is one reason why we are so eager to work with you and the committee. This concludes my statement. My colleagues and I are happy to answer any questions that you may have. Thank you.
Thank you, Dr. Carroll, for that, and thank you for being here. I will now recognize myself for 5 minutes of questions. The first question, Dr. Carroll, is to you. On my bill on mammography, I'm kind of frustrated by the VA's response on this. It's basically you're sort of saying, we don't really need this bill because we're already working on a strategic plan or have a strategic plan. I haven't had good success of recent anyway around strategic plans. I know another area of interest is mine is non-institutional long-term care. You know, they said they had a strategic plan. When I got the plan, it was a page and a half long. So it wasn't what I would call a comprehensive strategic plan. So I just wanted to know from you, I think my bill spells out pretty clearly what the expectations would be in a strategic plan, everything from evolving needs of women veterans, the needs of male veterans, geographic disparities, the use of non-VA providers for breast imaging services, the use of 3D breast imaging, recommendations on potentially expanding breast imaging services furnished at the VA, et cetera. So can you just tell me, what your strategic plan does and where it's trying to go? Where is it trying to take the VA in terms of all of this?
And this is Dr. Sherry. I'd be happy to take the question, Chairman Brownlee. This is Dr. Sherry of the teleradiology program. I hear your concerns, but we do currently have a robust strategic plan for the provision of breast imaging. It's in draft format. It's awaiting the concurrence process. The vision of the plan.
In the what process? I'm sorry.
Concurrence.
Oh.
Concurrence.
Okay.
The vision of the plan is for the VA to become the trusted lifetime partner of women veterans, responding to meet their evolving breast imaging needs in an equitable and proactive manner. And its mission is to provide high quality and accessible screening and diagnostic services to support early detection and improve breast cancer outcomes. And so it establishes 4 goals: access, outreach, quality, and veteran experience. It addresses each of those goals with action plans. It addresses both our in-house mammography services as well as our dependence on community partnerships, which is needed as well. Like I said, it's in draft format. We expect it to be completed in FY22, and we'd be happy to share the plan with the committee at a later briefing if you'd prefer.
Yeah, I will be very anxious to see the plan. Dr. Carroll, also you talked about peer support, and I mentioned to Representative Peters about women peer specialists. So do you know, in relationship to the whole population of peer specialists, what's the percentage of women peer specialists who are, more or less specialized and women experiences, et cetera?
We'd be happy to get you detailed information, but I do know, ma'am, that as of August of this year, there were roughly 19% of our peer support specialists in VHA were women veterans.
Very good. I wanted to bring up something. I just have a little bit of time left, but I wanted to bring something up that's not necessarily on the agenda today or relative to all of these really wonderful bills. But the Secretary McDonough came to my district last week. We had a chance to visit our vet center in Ventura County. And, they were talking a little bit about their frustration and sort of, I guess, the disconnect between the vet center and the VA medical facilities. That sometimes when they call, they don't even feel like the people who are working at the vet center are VA employees necessarily. And they were talking about during COVID, they had a crisis with an individual, and the only real way to stay connected with this individual was to get the individual an iPad to stay connected to them electronically. And, the VA just said, not my job, can't help you. And that was about it. So, they brought this up, and it just made me, I just wanted to bring it to your attention, because I don't know whether this is, an individual problem that's just occurring in my district, or whether it's a little bit more pervasive within the VA, but I wanted to make sure that you're aware of it. And if this is a problem, we need to be able to fix it, because it is a vet center should be able to call a VA medical center and get a response. And as I've said already in this hearing, the beauty of a vet center is that they are disconnected, from the VA bureaucracy, but they need to be connected when they need help and assistance. So I just wanted to bring that to your attention. So with that, we will move on to Dr. Miller-Meeks for questions that you might have.
Thank you so much, Chairwoman Brownlee, and all of our panelists. So I will ask, Dr. Carroll and Dr. Sherrier, in reference to HR 5529, how has the population of justice-involved veterans changed over the last several years? And how does the VA expect it to change over the next several years? And was there any impact of the pandemic on veterans' abilities to, justice-involved veterans to be able to access care or services or benefits?
Thank you, ma'am, for the question. And we'd be happy to work with our homeless program office that oversees the Veterans Justice Outreach Program and get specific information for you regarding what the footprint was during the COVID pandemic. But to pick up on the comments that were made earlier, this is such a critically important program in terms of looking at the overall health and well-being of veterans, minimizing suicide risk. The VJO program is already addressing all of the recommendations that are in the recent GAO report to make sure that we are providing more in-depth training as well as increasing staffing in the VJO program. And we'd be happy to get you detailed information about the utilization of the program during the pandemic. I don't have that available today.
Dr. Sherrier, if you don't have a comment, then I'll go on. You mentioned making progress to address the GAO's recent recommendations regarding the Veterans Justice Outreach Program. So you mentioned some of those as far as staffing, what other progress has been made, and when do you think the recommendations will be fully addressed?
Dr. Sherrier, you're on mute if you're speaking.
I'll defer that question to Dr. Carroll.
Thank you.
I don't have any further information.
I don't know the timeline for the addressing the recommendations, ma'am, but we would be happy to take that for the record and get that back to you. But I know it's under active consideration now, and the team feels that they will be close to closing those out relatively soon.
And how do you think the needs and challenges of justice-involved veterans in rural areas compare to urban areas? So most of my district is urban or rural, excuse me.
The needs of rural veterans in general is critical in the sense that there are fewer supports in rural communities, and we know that one of the greatest risks for having problems in terms of mental health, well-being, and suicide risk is a feeling of disconnected and not belonging. And those particular challenges, I think, are exacerbated often in rural settings. I think, which is why all of our programs that are addressing rural needs of veterans, all that we're doing to try and advance technology so we can, communicate effectively, web presence in those areas, recognizing that there are still challenges, but all of those programs to outreach to rural veterans, where in a small community, there can be additional stigma associated with mental health or with justice involvement or other things. And so I think those programs are particularly critical in those areas.
Thank you. And what percentage, if you know, are justice-involved veterans homeless at some point in time, or even for a transitory point in time, and what do you consider to be temporary homelessness?
I do not know those figures. We'd be very happy to get them for you, ma'am.
Okay. And then do you know what percentage of justice-involved veterans attempt or die by suicide?
They are a higher risk population, but I do not have a percentage to offer for you.
Okay, so it would appear that we do still have some work to do. Ergo, HR 5529, I think, helps to address some of those and continue the great work that you're doing in trying to meet the GAO's recommendations. And I would encourage my colleagues to support the bill. So thank you, Madam Chairwoman. I yield back my time.
Thank you, Doctor. Mr. Sibling. You're next for 5 minutes of questioning. Did we lose Mr. Sibling? Mr. Sibling? Ms. Underwood.
Well, thank you, Madam Chair. And thank you again for including my bipartisan VA nurse and physician assistant RAISE Act in today's legislative hearing. This bill, which I introduced with Representative David Joyce, would adjust VA's pay limitation for advanced practice registered nurses, physician assistants, and other registered nurses to ensure that VA can offer competitive salaries that will allow the Veterans Health Administration to recruit and retain top talent. The VA Nurse and Physician Assistant RAISE Act was based on a legislative proposal that was included in the department's fiscal year 22 budget submission. Dr. Ott, can you describe how the change in pay limitations for nurses and PAs included in the department's budget submission and reflected in my bill will improve VA's ability to attract and retain these healthcare professionals?
Thank you very much, Representative Underwood. Yes, the VA agrees that this is a necessary need for us to, as you said before, previously in your opening remarks, that VA needs to have the maximum flexibility of its pay to be competitive, especially in those high market cost market areas that are periodically around the United States, around the U.S. Itself. Both coasts and in the center, we have those places. And this bill would provide VA with that maximum flexibility to make sure that the pay is competitive so that we can, as you said, we can recruit and retain the highest skilled nurses and physician assistants to deliver the highest care for veterans.
Thank you. Well, ensuring that the VA offers competitive salaries is the right thing to do for nurses and PAs, and it's the best thing to do to ensure that veterans have access to the highest quality care. Dr. Ott, can you describe how VA's enhanced ability to recruit and retain the best nurses and PAs our country has to offer can ultimately improve health outcomes for our veterans?
That is, so I don't have specifics on that. In fact, Representative, I'd be happy to give you some specifics after the hearing today. But we know that where there are adequate numbers of nurses, advanced practice nurses, and physician assistants who are providing that care to veterans where they live in the rural, highly rural, and in all areas, that's where we do see the best outcomes, where we have the greatest amount of staff represented. I will be happy to give you examples of those after this hearing.
Thank you. You know, I think the alternative, we're not talking about higher salaries versus current salaries. We're talking about higher salaries versus workforce shortages, meaning that our veterans can't get in to get the care that they need, that we don't have the clinical workforce to meet demand, and that our quality outcomes will then decline. And so that's really where we're coming from. And I'm looking forward to working with our subcommittee to get the bipartisan VA Nurse and Physician Assistant RAISE Act passed and signed into law. Thank you so much, Madam Chair. And thank you to our witnesses for being here today, and I yield back.
Thank you, Congresswoman. Apparently, Mr. Sibling is not able to return to the hearing. He would be much more diplomatic in asking you the question, but I'm going to ask his question for him. When is the Mariana Islands going to get a vet center? That's my question for Mr. Sibling. As I said, he would have been a lot more dignified in asking the question, but that's what he wants to hear. So if you can't answer it now, please get back to him.
Actually, we can answer that now. And it's actually, ma'am, thank you for the question. We're excited to announce that we received approval for a vet center outstation on the Marianas Islands. So we will be bringing permanent counseling staff to do both outreach and direct counseling to the islands, and not just focus on Saipan, but be able to get out to the surrounding communities. So
what is an outstation compared to a vet center?
This is a place where we permanently assign at least one counselor into that community. And then some of our outstations have more than one counselor. It really is dependent on the need within that community.
So do you know what his need is?
That's what we're going to find out, ma'am, when we get that person on board.
Okay, very, very good, very good. Thank you for that. Ms. Rodawagen, you are next. It's the first time I've seen you without an orchid in your hair, ever, I think. So welcome.
I want to thank you, Chairwoman Brownlee and Acting Ranking Member Miller Meeks for holding this hearing today. I have some questions for Dr. Carroll. Are there any notable differences in breast cancer risk, diagnosis, or morbidity among veterans and non-veterans across both genders?
Dr. Sherrier?
Dr.
I do not
Carroll?
have the data. Yes, thank you for the question. I do not have that data available, but I can get it for you.
Okay. Anybody else on the panel? Well, I'd appreciate receiving it in the near future. As the women veteran population continues to grow, how is VA correspondingly growing its communications regarding mammograms and other gender-specific services and the availability of mammograms and gender-specific services?
Yes, I can. Thank you for the question. As part of our strategic plan, which I've referred to already, we have a robust plan to look at providing high quality breast services to all of our patients, especially women, but mammograms are also performed on men as well, as you know. We have to balance in-house mammography programs with partnership with the community. That's essential. It should be recognized that mammography is a challenging specialty in that in order to maintain high quality, both technically and in the professional interpretations, you need a certain volume of patients. So our strategic plan has to balance that and what is the best for the patient. You know, if there are not enough patients in the community to support high quality services, then we need strong partnerships with the community. So that's what our plan looks into and addresses those issues.
Thank you. And what is the ratio of mammograms provided to veterans in VA medical facilities versus through VA's community care partners? How, if at all, has that ratio changed over the last 5 years? Can someone on the panel tell me, please?
I don't know the statistics. I can get back to you on that as well.
Thank you. Thank you, Madam Chairwoman. I yield back.
Thank you, Ms. Radewagon. Mr. Rosendahl, you're last and questioning on panel 2 here. Welcome.
Thank you so much.
I've seen you all day long.
Yeah, and I have enjoyed being with you today.
Thank you.
Dr. Carroll, thank you for joining us today, and everybody, thank you for joining us today. Can you discuss some of the unique mental health impacts of losing a spouse, a parent, a sibling, or a child who's a service member?
Suicide has profound impacts, and we know from the literature that there are at least 135 other lives that are typically impacted by every death by suicide, you know, beginning with immediate family members, community members, co-workers, VA or community health providers, everyone who's engaged with that individual. And we know that exposure to death by suicide is in itself a risk factor that can increase the risk for others. And part of what we have done over the last several years at VA is put together a comprehensive, what we call a post-vention program that is staffed by our subject matter experts at the Rocky Mountain Mental Illness Research Education and Clinical Center and co-led by our suicide prevention program team, but to make sure that there are robust post-vention services available to family members, to providers. When there is a death by suicide, we have guidance available for facility leaders as well as clinicians. And we also work with community partners such as the TAPS program, you know, to provide additional support to make sure that individuals impacted by that. And as one of the bills is noting today, to make sure that the Vet Center program is also available to veteran and service member families.
So how do you believe that HR 5092 and how will it expand bereavement services and how will they be, I guess, customized, if you will, for these individuals? If we're talking about potentially touching 135 lives with each loss of a life, how do you cater those needs?
I'm going to ask if Mr. Fisher wants to comment, since this is would be a program that would be particularly housed within the Vet Center program.
Thank you.
Yes, and thank you, sir, for the question. First, I think let's talk about our current ability to provide bereavement counseling at vet centers, which is limited to family members family members who lose a loved one while that individual is serving on active duty. Regardless of war zone or what they were doing on active duty, and also family members of active clients. So this particular bill would actually expand our ability to reach those family members of veterans who die by suicide, which we do not have authority now. Now, to the second part of your question, really this speaks to the vet center approach of providing services, and that is our goal, or the work that we do with families as well as veterans and service members, is really to create an individualized counseling plan to meet whatever their needs might be, whatever their goals might be. And in this case, whatever their goals might be in the realm of bereavement.
Good deal. Thank you. Thank you very much for that. Back to you, Dr. Carroll. We all on this committee want to make sure that we direct these limited amount of dollars to the highest quality care for our veterans that we possibly can, and that we fully utilize every one of those dollars. In your testimony, I heard you say something about duplication of efforts, and I was wondering if you could expand upon that. You made reference to some kind of duplication of efforts, and I want to make sure that we are directing these dollars properly, and that wherever we can eliminate that duplication of efforts, that we do. So could you identify some areas where you think that those dollars are not being used quite right?
Yeah, thank you, sir, for the question. I think in terms of duplication of efforts, I think a big concern in our testimony and our consideration today had to do with legislating things that we are already doing, legislating standards that we may be meeting or exceeding already, and then getting locked into something and not having the flexibility to adapt. And I think a part of the concern about that is the cost, frankly, in terms of the agency time and staff time. If there are additional reporting requirements, for example, over and above what we're already doing and the information that we already make available to the committee, we're concerned about adding additional burden that could take our staff away from doing the great work that they're already doing. And we'd ask for your support and consideration in that.
Thank you. Thank you so much. And I see I'm over, Madam Chair, so I would yield back.
Thank you, Mr. Rosendell. And before we move on to the next panel, I had one more question that I wanted to ask of Dr. Carroll, particularly before we go on to the next panel, because I know they will be interested in your answer. And that is, you've noted in your testimony that the VA is monitoring smaller research studies on cannabis, but is opposed to starting any kind of rigorous clinical trial that's requested in Congressman Correa's bill. I know the VSOs and the mental health organizations support the proposed clinical trial. So, tell me why the VA is opposed to this, and if the VA is not going to do the research on the veteran population, then really, who is? I mean, I feel like the buck sort of stops with us. So if you could comment, please.
Yeah, absolutely, ma'am, and thank you for that question. And we are not opposed to research. VA, strongly supports research regarding marijuana for medical purposes, and we actually have one study already underway regarding PTSD treatment and the use of marijuana as an adjunct to psychotherapy, and another study on its use in terms of treating chronic pain that will be underway in January. I think the concern about the bill is that it is so prescriptive that it would be up. We want to do the research and we want to make sure it is well done research. And that means that we need to make sure that we are following the best scientific standards and having institutional review boards, approve of the research. So we get good outcomes, but we also don't put veterans at risk. And the size and complexity of the number of participants and the different levels that are outlined in the bill is so great that we do not believe it would get approved through the scientific process that we have. And we don't want to do anything other than the best science, and we don't want to put any veterans at risk. We are very interested in proceeding with this research, but the current language is too prescriptive, quite honestly, in our perspective, and we'd be happy to.
So if I understand you correctly, the difference between a clinical trial and research, whether you're not opposed to a clinical trial if the science leads you that way, is that what you're saying?
Exactly, yes. If the science leads us, we're absolutely in.
I mean, most of the time, you can't predict, I guess, the way science is going to lead you, but, outside of the VA, science is certainly leading towards, clinical trials and other kinds of things as it relates to medical marijuana. So at least I believe it does. So I just, if there are ways for you to work with Mr. Correa's bill, then we should be doing this, because I think, this is an important topic, I know, for veterans. I hear from veterans, all the time about this, and they really, really want to proceed. So if we can at least clarify that issue, that you're not opposed to, and that you likely anticipate getting to that place. But I think that would be at least be helpful.
We'd be happy to do that, ma'am.
Okay, and but just before I give up my time too, the other one thing that I just wanted to mention to you, Dr. Carroll, that's not part of this discussion, that I learned from the VA for the Vet Center when the secretary was with me last week, is they were really raising the issue of their concern about suicide risk flags within veterans' electronic health record are not always getting communicated to the vet centers. So you don't need to address it right now, but I want to make you aware of these 2 points that we heard with the secretary. And Dr. Miller-Meeks, would you like to ask some more questions? Floor is yours.
If you'll indulge me, Chairwoman Brownlee,
Yes.
Thank you so much. And I actually had one question, but since you brought up the medical marijuana research bill with Representative Correa, that brings up, having been a physician, having participated in IRB processes and clinical trials, I certainly understand the difficulty of that. And so first question is, are you familiar with my bill, HR 2932, or the Veterans Cannabis Analysis Research and Effectiveness or CARE Act? If you're not, you can just say that you're not. If you are, you would make, this may address some of Chairwoman Brownlee's questions. My second question is, I know that salaries for nurses, nurse practitioners, physicians, having worked within the VA organization, are based on locality. And this may be, Dr. Off's question, but can you tell us what the average ARMP salary is, throughout the country? I know there's ranges from state to state. If you can give us the lowest to the highest, and then how does Representative Underwood's bill with the raising the salary cap, how does that interface with what's paid in localities throughout the country? So thank you very much.
Yes, thank you for that question. That is really an excellent question to ask, because we do have locality pay surveys that are based on the locale. And because the VA can never be the pay leader, but we need to know what the pay is so that we can be competitive with that pay, so that we can recruit and retain those nurses in that particular locale. So what we need, our current cap is caused pay compression, as we mentioned before. And that over years, our nurses have hit the pay cap earlier and earlier in their career, and then it's hard to retain them and hard to recruit. Not in every area, specifically in those areas, like on the West Coast, San Francisco, Palo Alto, Greater LA, they have difficulty with the pay in those areas, and the market is changing rapidly because healthcare is changing, and it's longer for us to, without that immediate flexibility of the bill, it would be slower for us to be able to respond. Thank you.
And Dr. Carroll?
Yeah, going back to your bill, I'm not prepared to talk about that other bill today, and I apologize for that, but would be happy to look at it and to talk about it. But just to reiterate the point that I've tried to make to you and Chairwoman Brownlee, we want to make sure that there is solid scientific merit before we proceed into a randomized clinical trial. That is a major undertaking. We want to make sure that we can get reliable and high quality results. We want to make sure that we're minimizing risk to veterans who are willing to engage in a trial like that. And so we're very interested in this area of research, but we are just interested in doing it in the most scientifically sound way possible.
That's why I asked the question. And again, thank you, Chairwoman Brownlee, for allowing me to ask us a second question, was because it's not prescriptive in that it mandates a clinical trial. So it is research-based, very similar to what Representative Dr. Phil Rowe had presented before. So it might be good to familiarize yourself with that bill as well. Because I agree with Chairwoman Brownlee. I think it is an area that we should be discussing, that veterans are interested in, and having some knowledge and research, fact-based research, and then whether or not a clinical trial is necessitated, I think is the appropriate scientific approach. So, and that was HR 2932. So thank you so much, and I yield back my time, Chairwoman Brownlee.
Thank you, Dr. Miller-Meeks. It's always great to have a professional as a member of Congress, but on the committee as well. So thank you for that. And I don't think there are any further questions for our VA colleagues. Thank you all for being here with us today. I know each individual member who presented a bill today is going to want to work with you to find the right pathway to see their bills forward. So please be open to that. And you're certainly welcome to stay on Zoom to see what the third panel has to say with regards to these bills. So thank you very much for your participation. So panel 3, our last panel, we're pleased to have a range of stakeholders with us today. And we deem your insights on these pieces of legislation as invaluable. So thank you for being here. We have Mr. Marquis Bearfield, Assistant National Legislative Director for Disabled American Veterans. Ms. Tammy Bartlett, Deputy Director of the National Legislative Service for the Veterans of Foreign Wars. Dr. Keiki York Ward, the President of the Association of VA Psychology Leaders. I hope I came close to pronouncing your name correctly. And again, just to remind everyone, just a little bit of a pause before you speak so the recording can capture you. Your written statements will be included in full in the hearing record without objection. Mr. Bearfield, we'll begin with you. You are now recognized for 5 minutes.
Thank you. Chairwoman Brownlee, Ranking Member Bergman, and members of the subcommittee. Thank you for inviting DAV to testify at this legislative hearing and offering our views on the bills under consideration. My full written statement covers all the legislation, but I will just highlight a few bills in my oral remarks. DAV supports HR 2819, the Solid Start Act of 2021, which would require VA to contact newly separated service members over the first year post-discharge to help them access their full VA benefits and other resources to support a successful transition from military service. The bill would require VA to focus efforts on discharging service members who use mental health services prior to their separation. We support this bill to ensure that recently discharged veterans have better access to mental health services and the support they need to establish productive lives after military service. DAV also supports HR 2916, VA Medicinal Cannabis Act of 2021, which would require the VA to conduct clinical trials on the effects of medical grade cannabis on veterans with chronic pain and PTSD. Researchers would be required to evaluate if medicinal cannabis use has effects on veterans' osteopathic pain, inflammation, mood, anxiety, social functioning, and suicidal ideation and sleep quality in veterans with PTSD. Importantly, covered veterans participating in this study would not be at risk of having their eligibility for or existing benefits taken away. DAV supports comprehensive and scientifically rigorous research by the VA into the therapeutic benefits of cannabis and cannabis-derived products as a possible treatment for service-connected disabled veterans. Another bill DAV supports is HR 4575, the Veterans Peer Specialist Act of 2021, which will require the VA to make permanent and expand the Veteran Peer Specialist Support Program to all medical centers over a 5-year period. The bill would require each medical center to have at least 2 peer specialists and ask VA to prioritize medical centers in rural and underserved areas. Peer specialists are an important addition to VA's programs, and this bill would help to ensure that underrepresented veterans, including women, ethnic, and racial minorities, have a point of contact in a system that sometimes seems bureaucratic and unresponsive to their individual needs. Peer specialists can also help improve cultural and gender sensitivity that may be lacking in some VA healthcare facilities. For these reasons, DAV supports this bill to ensure there are sufficient peer specialists at all VA medical centers. Madam Chairwoman, DAV is pleased to support your bill, HR 4794, making advances in mammography and medical options for Veterans Act, which would require the VA to develop a strategic plan for breast imaging services and establish a telemammography pilot program in states and locations without these important services. The bill would also require VA to upgrade current mammography equipment to 3-dimensional imaging and to study the availability of genetic testing for breast cancer genes in veterans. 1 of every 8 women will have invasive breast cancer during their lifetime. Breast health is essential to women's health, yet women veterans do not always have adequate access to these vital services. DAV supports this legislation as it would expand enhanced mammography services and benefits for women veterans. DAV is pleased to support HR 5073, Reach for Veterans Act, which would require a review of training protocols for veterans crisis line responders to improve the quality of the program. The act would also require enhanced guidance for managing callers with substance use disorder who are at risk of overdosing. Over the past decade, Congress, VA, and DoD have been steadily working to improve prevention efforts to address the epidemic of suicide among service members and veterans, including those who suffer from substance use disorder. There have been some troubling lapses in the quality of the veteran crisis line that lead to adverse events for veterans, and DAV supports this legislation because it would increase training and oversight to help strengthen these vital services. And finally, we are pleased to support Chairman Takano's bill, HR 5317, VA Governor's Challenge Expansion Act of 2021, which would require the VA to operate a grant program for technical assistance to state or Native Americans and Alaskan Natives to develop plans to provide suicide prevention services. Madam Chair, this concludes my remarks, and I welcome any questions that you or members of the subcommittee may have.
Thank you, Mr. Beerfield. We now we will go on to Ms. Bartlett from Veterans of Foreign Wars. So welcome. Thank you for being here.
Thank you, Chairwoman Brownlee, Ranking Member Bergman, and members of the subcommittee. On behalf of the men and women of the Veterans of Foreign Wars of the United States and its auxiliary, thank you for the opportunity to provide our remarks on these important pieces of legislation pending before this subcommittee. The Senate Veteran Affairs Committee held a hearing earlier this year addressing several pieces of legislation in today's hearing. HR 2819, the Solid Start Act of 2021, HR 2916, VA Medicinal Cannabis Research Act of 2021, and the discussion draft to amend Title 38 to expand eligibility of special services to World War II veterans. The VFW supports the House version of these bills and urges Congress to vote and pass them to the President's desk before signature before the end of the year. The VFW supports all bills on the hearing docket, and further narrative can be found in my written testimony, but I will take this time to highlight just a few. Recently, a VFW member who is a post 9/11 veteran shared their vet center experience and how they continue to benefit from those services they receive. Only a few days after they transitioned from active duty to civilian, the veteran began pursuing their education and soon came to realize they required mental health help immediately. The closest VA facility was over 2 hours away. Thankfully, a vet center was located just off campus. The vet center staff coordinated individual and group counseling, arranged for the veteran to attend retreat specific to their trauma, and assist the veteran in fulfilling their compensation benefit paperwork. The veteran is forever grateful that the vet center was located within close proximity to the campus. It allowed them to manage school, transition, and receive the mental health services they desperately needed without driving a 4-hour round trip to a VA facility. Vet centers are a great VA program, but that program's growth has been stagnant, and the lack of resources the program needs to continue impedes its success. Some communities lack access to vet centers, while others experience demand that exceeds their vet center capacity. The VFW supports a discussion draft, which would require VA to increase the number of vet centers, which are vital community-based lifelines for mental health care, and readjustment services for veterans, service members, and families. The VFW, in partnership with the Student Veterans of America, is now in our 8th year of offering the Vfw Sda Legislation Fellowship. This program provides exemplary VFW members who are student veterans the opportunity to make their voices heard on Capitol Hill and in their communities. Proposals range from child care access for student veterans, oral care as preventative care, the patient advocate complaint tracker system, and a Department of Defense housing comparison tool. VFW SBA legislation fellow and the Ohio State University student Eric Sowers focused his semester-long research project on the Veteran Justice Outreach Program. Sowers' research indicates that some justice-involved veterans have no access to VA. However, the Veteran Treatment Court's treatment plan requires them to enroll in a local VA medical facility to connect with physical and mental health care they may need. As the demand for VTCs increase, the program's success faces barriers and challenges due to a lack of financial support, open-minded prosecutors, and reliance on judges to volunteer for the position. While the VFW realizes veterans who are convicted of crimes must suffer the consequences, we also realize that having veteran advocates or individuals to represent them before sentencing and act in their best interest is invaluable. In addition, only a small number of studies on veteran treatment courts have been done over the past few years, effectively making the research on their efficacy scarce. The VFW strongly supports the discussion draft that would improve the VA's VGAO program and require a report detailing the program's performance goals, measures, training, and timelines. Chairwoman Brownlee, Ranking Member Bergman, this concludes my testimony. I'm prepared to answer any questions you or the subcommittee members may have.
Thank you, Ms. Bartlett. I appreciate that. Dr. York Ward, welcome. I understand this is the first time you have testified at a VA hearing, perhaps, so we want to give you a very warm welcome. Thank you for being here.
Thank you for inviting me, Chairwoman Brownlee, Ranking Member Miller Meeks, and distinguished members of the subcommittee. As Chairwoman Brownlee just mentioned, my name is Khaki York Ward. I am a board certified clinical health psychologist, and as some of the members of the panel are aware, in my day job, I am also a clinical executive for mental health at my local VA. It's really important to me that you know then that I'm not here in my capacity as a VA employee. I don't represent the department or its views. I'm here in my own capacity as a United States citizen and in my role as the current president of the Association of VA Psychologists. The views that I'm expressing today and in my written testimony are those of AVAPAL, and again, don't reflect VA's position. I'm on personal leave this afternoon and not using any government equipment in order to provide you with my testimony. For those who are not familiar with AVAPAL, it is the largest professional body representing psychologists within the VA. Last count, we had some 1,400 members. Those members include trainees, clinicians, researchers, and even staff in central office and the VISN. AVAPAL members are on the front lines of caring for our nation's veterans. We see the impact that military service has on our men and women in uniform, their families, and the communities that they come from and are part of. We also see the impact of VA policy and federal legislation on the way that we're able to care for our veterans. In general, AVAPAL supports new and innovative programs that will improve access to and quality of care for veterans. We strongly believe that any new programs or expansion of old programs must include funding increases specifically for those services. And that's because we've heard anecdotal evidence from our members that clinicians have been diverted from providing patient care in order to serve in administrative roles for new programs, which has had the effect of reducing access to that care for our veterans, care that they've earned through their service. VA is on the cutting edge of mental health research, treatment, and wraparound services, something we're tremendously proud of and that we want to see continue into the future, but that innovation can't come at the cost of access to in-house VA care. For the bills that AVAPAL supports here, there needs to be requisite funding increases or a fencing process to ensure that the intent is implemented faithfully and doesn't impact ongoing patient care. While there are many important bills on the agenda this afternoon, because of time, I'm just going to highlight a few of the ones that impact the psychologists and the veterans that we care for. First, we'd like to announce our support for the Solid Start Act. There's significant evidence that suicide risk is highest within the first year of transitioning from military service to civilian life. This first year is clearly a period of vulnerability for our veterans, and there's specific subgroups of veterans who are at even greater risk compared to their veteran peers. Veterans who are younger, who are male, are much more likely to die by suicide in that time period. The Solid Start program has already shown success in contacting veterans and getting them connected with VA resources. And we know from other research that there's good evidence that outreach to those veterans in transition periods and those experiencing suicidal ideation, sometimes we refer to that as caring contacts or caring communications or low demand interactions, that those reduce suicide. So we really want to support and encourage additional efforts on behalf of veterans who are transitioning. AVAPAL also supports expanding the Families of Veterans Access to Mental Health Services Act, because losing a family member to suicide is very challenging. And it's an important time for those experiencing loss to have access to mental health care. There's anecdotal evidence from AVAPAL members that VA facilities and veterans centers are already serving families of veterans who die by suicide, but this new act would help to codify and provide great benefit to the families and of the veterans and service members who die by suicide. This is particularly important in terms of resourcing, because the vet centers are already in the process of implementing the Care for Reservists Act, which we think is also going to be very beneficial. And lastly, we want to provide our support to the VA Governor's Challenge Expansion Act. This act provides high quality mental health care and suicide prevention services to veterans through partnership with the community, because VA can't do it alone. But the early program ideas that the Governor's Challenge has identified didn't come with their own funding, and we'd like to see that be part of the plan. VA AVAPAL recognizes the critical importance of a whole nation approach to addressing and preventing veteran suicide, and is proud to support that bill. And I know I said it was last, but I'm going to throw one last one in. For Representative Underwood, we were so pleased to hear about your bill supporting flexibility for hiring nurses and PAs. We'd also like to remind everyone that psychologists are an underserved discipline, among the hardest to recruit in all of VA. And if there was a way to include psychologists in that act, we would be very pleased to see that as well. Thank you. And please let me know if there are any questions that you have.
Thank you very much. Perfect testimony. Thank you, thank you, thank you. And I will now recognize myself for 5 minutes for questions. Mr. Bearfield, in your written testimony with regards to my mammography bill, you stated that anecdotal research indicates that women receiving care in the community are often dissatisfied with communication about scheduling appointments and accessing results of diagnostic work completed. Can you give us some examples and expound on that a little bit?
Thank you for the question, Chairwoman. What we mean by that statement in my written testimony is that some women veterans who've been referred to the community that use the mammography services that they are sent out for, the results often take quite a bit longer to receive, and sometimes the information may be incomplete. So that's the reason why they may express reasons for dissatisfaction. So that's the reason for that statement that is or the reason that written statement is there.
Okay. Well, I know, there's just not that much mammography across the VA. So, the preponderance, I think, of women are getting their health care services in the community. So, making sure that the community is responsive to them is important. Would you say that women prefer to go to the VA for a mammogram than in the community? Do you have any sense of that?
I don't have any specific sense of that. I can only speak from personal experience because of my wife. We live quite a bit of ways from a actual VA medical center, and a lot of her care is referred here locally into the community area. The only thing that she says is that some of the providers need to be a little more sensitive to women veterans and their needs in their care across the board, not only with mammography, but with OBGYN and everything else. So that's the only issue that really needs to be addressed. It's not a matter of whether they prefer to go to the VA or not. It's just when they do go out into the community to make sure that those providers are sensitive to the fact that, one, they are a woman, two, that they are veterans and they serve this country, and they need to be treated with respect and dignity as well.
Thank you for that. Ms. Bartlett, do you have anything else to add to that line of questioning at all?
Yes, thank you, Chairwoman Brownlee. I can say from personal experience, I was very happy when I came down here to the DC area, and I knew that the DC VAMC would have their own mammography suite. But unfortunately, the first time I was rescheduled because of equipment issues, then I was rescheduled because the radiologist was on maternity leave. So I was sent across the street to the community care provider and did receive my film there. There was some question about some mass shadowing. Unfortunately, the VA was unable to provide my films from previous mammography graphs that I've gotten in the past in the community. All they had was the radiology reports. So unfortunately, I did have to go for a biopsy. I'm glad it turned out just fine. But as VA testified, or in their written testimony, they stated, one of their barriers is acquiring that previous mammography examination from outside community care partners. And that's why it's so important for this bill and the pilot program that will help eliminate that barrier and require VA to not only read, but diagnose and digitally store those community care provider mammography films versus just a radiologist report.
Right. That's a very important point. Thank you for sharing it. And I'm glad your biopsy came out positively, favorably. So, I'm sorry that you had to go through that unnecessarily, perhaps. So So, Ms. Bartlett, you in your testimony, express VFW's strong support for Mr. Correa's marijuana bill. So, talk to me a little bit about that. How long would you say your veterans have been waiting for VA to conduct rigorous scientific studies about cannabis, and if cannabis can be effective treatment for veterans with conditions like chronic pain and PTSD, and this clinical trial element did you glean anything new from what the VA testified earlier today? If you could just expound on that a little bit.
Thank you, Chairwoman Brownlee. Yes, veterans have been waiting far too long for this research to start. And like VA stated, they're doing the research, but we haven't seen the study results. We haven't seen preliminary data or even the research plan that they gave to the IRB for review. We need to make sure and keep them accountable that why can they not show us this material or show us where they are in the process? Be transparent in the studies that you already have going. Depending on the hypothesis that you have for a study is going to be depending on what type of research plan you have going forward. And we want to ensure that the validity and the reliability of those studies going forward are exactly what we need to see to make those judgments going forward.
Thanks for that. So, Dr. Miller-Meeks, you're recognized.
Thank you, Chairwoman Brownlee, and thank you to all of our panelists who are here. I'm going to echo Chairwoman Brownlee's comments that you did very well, Dr. York Ward, in your first testimony to a VA, and also Dr. or Ms. Bartlett, that very glad your biopsy turned out negative, which was favorable. And so very, very quick pivot there, Chairwoman Brownlee, you're very fast on your feet. Several of you have mentioned medical cannabis, so I'm just going to ask if you're familiar with my bill, HR 2932, the Veterans Cannabis Analysis, Research, and Effectiveness or CARE Act. And if you're not, I think that you've indicated the importance of having research into medical cannabis and the effect that it may have in improving PTSD or other mental illnesses that our veterans may suffer. Any of you familiar with 2932?
I haven't seen your bill, Representative Miller-Meeks, but I will be reading it as soon as we're off this call. What I would say is that in my preparation for this testimony, I learned that 57% of all veterans admit that they have used marijuana at some point in their life, and that about 24% are using at any point in time, which was, that's a pretty strong motive to want to understand what marijuana is doing to or for veterans. And all the data that I've read so far looks like it's correlational and primarily retrospective studies. So something that's forward-looking, like a clinical trial, would be extremely helpful in terms of providing clinicians with the information that they need to do a risk-benefits analysis with a particular veteran.
Great. Thank you so much. And then for any of the panelists, in reference to 5092, expanding the families of veterans' access to mental health services, I think you all mentioned this in your testimony. Other than enacting HR 5092, the expanding the families of veterans' access to mental health services act, how else can we support the family members and loved ones of veterans who die by suicide as part of our broader efforts to prevent veteran suicide altogether? Any one of you can answer.
Thank you for the question, Congresswoman Miller-Meeks. I think what we also need to address is ensure that those families, those lost survivors, are established in what they need as far as their social determinants of health. We want to make sure that they are housed and they do not have food security and they're able to succeed past the loss of their loved one.
Dr. Yorkford, go ahead. I think you wanted to add something.
I did. Thank you so much. So speaking as a family member of a veteran, not just a person who provides services to them, I think that the topic that we discussed earlier about enhancing access for rural veterans is really important. So many of our veterans live in rural communities where it's practically impossible to access mental health services. Anything that we do that enhances access to care in those areas is going to be really important. Providing family members with education, one of the things that VA likes to do, and which I think we're particularly good at, but could potentially do more of, is coaching veterans into care. So many times family members are calling, looking for help, getting their veteran who is struggling into treatment. They don't know how to access the resources, and they don't know how to convince their family member to even consider or try it. So more things that we could do educationally and support-wise, getting the message out. A year or so ago, there was a big push on national television with commercials around major sporting events to tell people about the crisis line and how to access it. Things like that increase awareness, I think, among family members so that they can help their veteran access the care that already exists.
Great, thank you. And then Mr. Beerfield, did you have anything you wanted to add? I don't want to leave you out.
No worries about leaving me out. But just as the doctor mentioned, the ad campaigns, some of those ad campaigns for lethal means safety and suicide prevention efforts, they actually have started to come back. I was on a panel that kind of tested some of that or looked at some of those commercials or some of those advertisings, and we gave good comments and feedback. So the current message that's out there now is something that we all looked at and gave comments on. So those advertisements actually have come back and started again.
So more educational outreach. Thank you so much. I really appreciate all your presentation. Thank you, Chairwoman Brownlee. I yield back my time.
Thank you for that. I'm going to ask one more question before we leave here, and certainly Dr. Miller makes you have that ability as well if you want to ask additional questions. I know our members, the rest of our members on our committee have left us. Today is a very busy committee hearing day. I'm scheduled for 3 committee hearings today, so I know members are juggling to trying to get to every place that they need to be. But Dr. York Ward, I wanted to ask you a little bit more about you in your written testimony. It states that due to restrictions from Drug Enforcement Administration and other federal bans, little research has been done on the safety and efficacy of medicinal cannabis for either civilians or veterans. Can you help us to understand what research has been done, and if there's any, research that is, the most superior research that's out there around this? And a little bit more about what VA should be doing with regard to that. And I'm a particular advocate for, the whole committee is, but I advocate strongly for our women veterans. And any insight that you might have in terms of what your organization has done and what within your own practice, if you could kind of comment on differences between our male and female veterans as it relates to just being women serving in the military versus men serving in the military, and how the VA needs to respond to that.
So let me take the first part, which is what do I believe is the current state of the literature regarding the use of marijuana as a medicinal treatment, whether for veterans or otherwise. Preparing for this meeting, I did a literature search and was able to locate a number of meta-analysis or systematic reviews, one of which was published just this year, actually in January, looking very specifically about marijuana use among military veterans. And it's a study collating 500 other smaller research projects all into one big meta-analysis, basically. Well, it's more like a systematic review, less like a meta-analysis. The gist of the study, though, is that while marijuana use is extremely common, and there have been a number of articles published that suggest a high degree of correlation between anxiety disorders like PTSD, for example, and depression, and some negative socioeconomic outcomes like decreased academic achievement, marital problems, and maybe also some medical problems in veterans who use marijuana. There's no ability to draw a causal link between the use of the marijuana and the negative co-occurrence. So I can't tell whether they already had a problem and they were self-medicating by using marijuana, or if they used marijuana and it caused them to become depressed or anxious. Does that make sense?
It makes sense. Yep.
There is one study out of Canada that is a retrospective analysis that specifically looks at the use of marijuana in treatment of PTSD. And that study did suggest some positive improvement on patient outcomes in veterans, Canadian veterans, not American veterans, but still veterans. And to me, that does suggest we at least need to look into it. With regard to the question about women veterans, they are a unique group of people. It is a totally different thing to be a female warrior than it is to be either a male veteran or just a woman on the street as a general member of the population. My experience of women veterans is that they're much more likely to have struggled with sexual trauma, whether in the military or before it, that they have unique physical health needs, and that it really is beneficial when we can make it happen to have women's health centers in our VAs that are specially trained and qualified to meet the unique needs of women veterans. And I think that many women prefer to receive their care in that context as well. Not every veteran, but many of them. And that's also true for their mental health needs. Women veterans prefer to have their mental health needs addressed in the women's clinic when that's where they're already getting their care. We've had a lot of positive feedback about increased integration of mental health services into that environment. So I would personally, and I think many other VA psychologists would like to see that continue to happen.
Thank you very much for that. Dr. Miller-Meeks?
I don't necessarily have a question. I'm just going to follow up on your question, which was actually an excellent question, and that is research into medical marijuana. And I participated in our medical marijuana board meetings here in Iowa, trying to gain more knowledge on this. And one of the problems is that because it is a illegal substance on the federal level, it makes it very difficult in the United States to do research. So as Dr. York Ward mentioned, we have meta-analysis, we have other literature, but the best literature actually comes out of Europe and out of Israel in regards to medical marijuana, which was why I put forward this study, was so that we could try to get information on a federal level in a federal program specifically to veterans about medical marijuana and its utilization. So I think it's an excellent question. It's one of the reasons why I continue to push to have the DEA classification changed. And I understand the hurdles on that, but for us to be able to do research in the United States, already we have states, your state is one of them, that has both, recreational and medical marijuana, and we still don't have, how to detect impaired drivers. We know some of the effect that it has on young people. There may be some accentuation of depression, but it does treat PTSD in some of the studies, as Dr. York Ward alluded to. So it really is actually a very important question and avenue of research that we need to engage in. So thank you for the question. I thought it was an excellent question.
Thank you.
And I yield back.
Okay, great. Thank you. And I think this concludes our hearing, and just want to thank all of you for being here and testifying. Appreciate it very, very much. And Dr. Miller-Meeks, if you have any closing comments you'd like to make, now's the time, and then we will adjourn.
I just want to thank Chairwoman Brownlee, the regular ranking member, General Bergman, and all of our panelists, both in this panel and panelists 1 and 2, for being here and for holding the subcommittee. I think it was very important that we discuss these bills and hear hear your viewpoint and your testimony in reference to them. So thank you very much. And thank you, Chairwoman Brownlee.
Yeah, thank you. And, I'll just conclude by saying that, this hearing isn't about just hearing the bills for the sake of hearing the bills and knowing that they're out there. This hearing is about, getting the feedback on these bills and getting the members who are carrying the bills and the folks like you, as well as the VA, to weigh in on these bills, to get the bills right, to move them along to the Senate and get them on the president's desk. We're like serious about these bills, and I think this is an important meeting with important legislation that I think every piece of legislation that came before the committee today has merit. And I hope that all of the VSOs and others will work with these members. The VA will work with these members to really see these bills through. So again, I just thank everybody for their attendance, for their perspectives and insight. It's been an interesting meeting. Thank you. And with that, I will adjourn.